Yes, ma'am.
Okay, fine. Very good evening to all of you in this scientific session. This is Dr. Manisha. I'm taking care of specialty group of Lupin Medical Affairs as a medical lead in the gastroenterology and hepatology segment. As we are aware that lupin has a strong footprint in the gastrointestinal segment and dedicated to dissemination of the knowledge across the medical fraternity. On behalf of my team, I extend a warm welcome to all of you in the scientific program of Gut Connect. This program mainly provides us opportunity to learn from the best in the field of gastroenterology and hepatology, and also it helps to enhance our understanding of complex cases and the knowledge which is associated with it. It is my privilege and pleasure to introduce today's renowned experts in the field of gastroenterology. Please join me welcoming Dr. Shobna Bhatia. She is the chairperson for today's meeting, and she will help us moderating this session. Dr. Shobna Bhatia is consultant gastroenterologist in the Critic Care Asia Multispeciality Hospital, Mumbai. Then we also have two other speakers with us today who will be taking us through two topics. First topic is about clinical presentation and diagnosis of functional dyspepsia. Will be taken by Dr. Lokesh LV. He is consultant gastroenterology segment with Sparsh Hospital, Bangalore. Then second topic is about the management of functional dyspepsia and the role of acosamide. Professor, who is professor and department, which will be taken by Dr. B. Avinash, and he is a professor department of gastroenterology from MS Ramaiah Medical College and Hospital from Bangalore. So I request all the audience to post their questions in the chat box. And with this brief introduction, I will hand over session to Dr. Shobna ma'am. Ma'am, over to you.
I think what I just have to say is that functional dyspepsia is a very important topic for all of us. And though it sounds very easy to manage these patients, it's actually very difficult because the spectrum of disease is extremely wide. And some patients just don't get better with whatever treatment you provide. So I will now go over to Dr. Lokesh and invite him to talk about the clinical aspects of functional dyspepsia. Dr. Lokesh, please.
Yeah, thank you, madam. So at the outset, I'd like to thank Lupin for this wonderful opportunity and taking me on board. So please, can you share me the slides?
Yes, sir.
Yeah. Okay. So
Yes,
we know that it's a dyspepsia is a global disease like present across the world, and almost 20 to 25% of the outpatient consultation for a GP comes through this functional dyspepsia. Can you change once? Next. So it's an umbrella of term encompasses number of symptoms throughout originate from the upper GI tract, and it's dyspepsia literally it's like a difficult digestion or bad digestion. Basically, it originates from the gastroduodenal region, where the predominant symptoms are postprandial fullness, early satiety, or epigastric pain or burning pain, epigastric burning pain, and there's various associated symptoms along with this. So, in general, worldwide studies shows that 20 to 25% of general population is affected with this. Next. So, when you work up a dyspepsia cases like where there are organic dyspepsia or functional dyspepsia or secondary dyspepsia or primary dyspepsia, out of the 70 to 80% they fall into age in functional dyspepsia group. When we thoroughly evaluate, it is very difficult to differentiate between organic and functional dyspepsia based on the symptom approach. Always we need to evaluate with other tests like especially endoscopy and other tests. that I'm going to discuss later. Next. As I said, like it's a global problem, and where the prevalence rates are, we don't have much prevalence studies in India, and many anecdotal reports point says that 7% to 49% of Indian population suffer from dyspepsia. Uh, Out of that dyspepsia, there's a difference between West and East, where in the West it is morely it's like ulcer-like symptoms or reflux-like symptoms, but in Indian population or Asian population, it is more of dysmotility-related dyspepsia. Like predominantly, they have symptoms related to either postprandial fullness or bloating. And among the Western population, in few studies, they show like it is more common among the low socioeconomic class, but in Eastern studies, which shows it is quite a more common among the high socioeconomic or upper middle class people. So in a Western population where the prevalence of H. pylori is low, eradication of H. pylori will have 10% therapeutic gain compared to placebo. But in Eastern studies, especially in Asia, in India and other Asian countries where the gain is 15 to 25% compared to the West. Several factors influence the H. pylori. Several factors influence the functional dyspepsia, especially prevalence of H. pylori, diet, female sex, and lifestyle characteristics, and may contribute to these differences. Next. So whenever the patient comes with upper GI symptoms, especially there's a lot of overlap between the functional dyspepsia and reflux disease, as well as gastroparesis. And also sometimes the abdominal discomfort or bloating we can confuse with the irritable bowel syndrome or lower GI symptoms. So whenever the patient have more specific symptom towards the reflux kind of illness, then you can label it as gastroesophageal reflux disease and can evaluate further with a PPI trial. Or if the patient have symptoms more not are not responding to the PPI, then we can investigate further. Basically, it is to rule out critical illness like organic disease. So where after investigation, where we do the endoscopy, then we label it them as organic and functional. So in functional, again, predominant symptom based on predominant symptoms, we label them as phenotypically epigastric pain syndrome type or PDS type, like postprandial distress kind of symptom. Next. So one thing is when to do an endoscopy. Most of the time, like in the West, because of the financial implication or because of the easy accessible, not accessible to the endoscopy, where they always have a criteria when to do an endoscopy whenever the patient presents the first time presentation of dyspepsia for longer duration, where this I've taken it from the BMJ journal, where they say like cutoff is 55. Whenever first time patient age more than 50% new onset dyspepsia, please do an endoscopy to evaluate underlying serious illness or evidence of GI bleed, melena, metastasis, or anemia, or progressive dysphagia or odynophagia, persistent vomiting, unintentional weight loss. And whenever the family history of gastric cancer and esophageal cancer, we need to evaluate them early with an endoscopy rather than wasting time on giving a PPI and other trials. So palpable abdominal mass, epigastric mass, and abdominal adenopathy where require endoscopy as well as CT scan abdomen to rule out underlying other pancreatobiliary cause for dyspepsia. Next. So these are the various other organic causes for dyspepsia. So we have luminal causes like ulcer disease, GERD, gastroparesis, malignancies, infective and infiltrative diseases, gastric infections, and food intolerance, and many other things. And associated with other pancreatobiliary diseases like biliary pain also can present like dyspeptic symptoms. Post lipid intake, they will have dyspepsia or pain abdomen. So sometimes we get confused this with dyspepsia. So, and chronic pancreatitis and pancreatic neoplasm. And the systemic disease also play an important role. We can confuse with dyspepsia. So, certain drugs also causes a low-grade inflammation in the stomach, which can also give rise to dysmotility, can impair the gastric motility and present with the dyspepsia. So, we need to thoroughly take a clinical history to evaluate and differentiate between the organic and functional dyspepsia. Next. So there's no shortage of hypothesis to explain the functional dyspepsia because many overlap happens and many times not every individual have a similar hypothesis. We can establish a similar hypothesis in each individual. Where delayed gastric emptying, we see similar delayed gastric emptying even in a gastroparesis also, impaired gastric accommodation to the meal, like fundic accommodation failure, are hypersensitive to the gastric distension. Either it could be physical distension or it could be chemical action. Low-grade mucosal inflammation, the duodenum, and sometimes duodenal hypersensitive to excess acid production or excess of oily stuff like lipids, duodenal dysbiosis, genetic predisposition, and associated H. pylori infection. So post-infectious, similarly like post-infectious IBS, there's an entity called post-infectious functional dyspepsia, where when the patient suffers from salmonella enteritis or some other giardiasis and all, they usually say like following this infection has started this dyspepsia symptoms. So similar to post-infectious IBS, they will also develop post-infectious functional dyspepsia where symptom will persist for 3 to 4 months and slowly it will improve. And it's basically a kind of dysbiosis happens secondary to the infection. And psychological factors. Next. This is where the diagrammatic representation was showing impaired accommodation, which is you can see in the upper part of the fundus, and there's a delayed gastric emptying and H. pylori infection, and duodenal acid exposure and lipid exposure, excess acid, and because many patients says like after taking fatty meal I get dyspepsia, otherwise they can well managed. Sometimes increased gastric motility also as hypothesized in PDS patient presenting with dyspepsia, nausea, and vomiting. And we have seen various studies have shown from functional to the involvement of whenever we personally evaluate thoroughly, in future also probably, we can say like functional dyspepsia can become more and more we evaluate thoroughly, it can enter into the area of secondary dyspepsia, secondary dyspepsia or organic dyspepsia. Sorry, yeah. Organic dyspepsia, where you can see the inflammation, increase IEL cells when you take a biopsy from the duodenum, and increase eosinophils in the duodenum. And what they've seen is the patient with functional dyspepsia, there's heightened expression of TRPV1 receptors on stimulation, whether it can be a gaseous distension, it can be a food, or it can be a chemical. Example like a chili containing capsaicin, any kind of irritant can stimulate this receptor, and which can stimulate substance P and other enterochromaffin cells and can give rise to symptoms related to the functional dyspepsia. Next. So this association between the pathological hypothesis and symptomatology in functional dyspepsia, a delayed gastric emptying can give rise to postprandial fullness and nausea and vomiting. Normally what happens now, the bloating related issue we can see in IBS also, where in SIBO IBS, where it is mainly after 2 to 3 hours of meal. Here, when it develops within 30 to 40 minutes of meal, that indicates there's a gastric emptying delay. It can be gastroparesis or it can be postprandial distress syndrome secondary to delayed gastric emptying. So hypersensitive gastric distension can give rise to epigastric pain, belching, weight loss. Impaired accommodation leads to early satiety, and they can't drink or eat more. And H. pylori infection can give rise to epigastric pain by various means, by chronic active gastritis or atrophic gastritis or sometimes peptic ulcer disease. And lipid hypersensitivity can give us to nausea, and even acid hypersensitivity to the duodenum gives us to nausea. And duodenal eosinophilia can give rise to early satiety, postprandial fullness, and abdominal pain. So these are the various pathophysical mechanism and their corresponding symptomatology. Next. So it has been hypothesized in a few studies where that most of the patients who have a PDS, 40% will have impaired accommodation on deep research, okay, and delayed gastric emptying seen in 30% of the patient, and hypersensitivity to gastric distension seen in 37% of patient. Next. So this picture representing how the meal, post-meal, the dilatation should happen in a normal person. You can see in the first lane like fundic accommodation and receptive relaxation. So 40% of the patient with the PDS patient, you can find that there is no fundic dilatation post-meal. So this patient will have early satiety features. Next. So meal-related other functional dyspepsia symptom where the lifestyle factors also impact the functional dyspepsia, where excess of stress, anxiety, smoking, coffee, excess of alcohol intake, overweight, obesity. So all this leads to development of functional dyspepsia. So these are the triggers so that they can, if the patient feels these are the triggers can impact the disease, then they can avoid these things. And specific foods, especially high fatty meal and acidic foods and hot and spicy foods, high caloric foods, all can give rise to functional dyspepsia or trigger the functional dyspepsia, so they can avoid. And heavy meal size also increases the trigger. It acts as a trigger for the functional dyspepsia. Next. So basically, what symptoms the functional dyspepsia present? The main symptoms are epigastric pain or epigastric burning sensation, postprandial fullness, and early satiety. And other associated symptoms, which are there in many other diseases like bloating, belching, nausea, and vomiting and weight loss. So with this, the Rome 4 criteria, they've derived phenotypes. Next. So if any one of the symptoms or more than one persist for more than 6 months, at least in case of PDS, it is 3 days a week, or in EPS, it is more than 1 day a week, persists for more than 3 months, onset is more than 6 months. Then we can label them as a PDS or EPS. If the symptoms like early satiety and postprandial distress, then they label it as post PDS. When if it is burning sensation or pain abdomen, then we can label them as EPS. With respects to their prevalence, like most of the time, PDS is common in the East and EPS is common in the Western world. There may be overlap in many patients. Some people will have PDS early and later they will have EPS kind of symptoms, or sometimes same patient will have both the symptoms. Next. Next. So one more differentiating point is always this postprandial distress syndrome, especially PDS type, should be differentiated from GP, because when you look at the hypothesis or pathophysiology, both will have a lot of overlapping, like delayed gastric emptying, impaired gastric accommodation, abdominal duodenal feedback, visceral hypersensitivity. We see both in gastroparesis as well as functional dyspepsia. In such a case, like always, we should evaluate thoroughly, like delayed gastric emptying studies, to rule out the GP from functional dyspepsia. Next. When you look at the etiology also there is some overlap between the functional dyspepsia and gastroparesis, where medication, post-infectious causes and idiopathic causes are also. Most of the thing, even FD is idiopathic and GP is also idiopathic gastroparesis. There will be a lot of overlap, so that we need to thoroughly evaluate whenever the patient is not responding to the functional dyspepsia symptom, we need to rule out the gastroparesis. Next. Next. So in a nutshell, whenever you come across a dyspepsia patient, so based on the symptomatology, because basically you are dealing with the symptoms. So symptomatology, it is more of epigastric burning pain or discomfort, then start the empiric PPI therapy. If the response is fine, otherwise test and treat for H. pylori. In a low prevalent area where they cannot access to the endoscopy, they can do the H. pylori testing by non-invasive methods and then they can treat. If no response or if there is a prompt EGD is required, if there one is the age criteria and the one is a warning signs are there, then we can subject them straight away to endoscopy and diagnose. Next. So uninvestigated dyspepsia, endoscopy, label them as organic dyspepsia or functional dyspepsia. So then based on the functional dyspepsia, then the management changes based on the phenotype. Next. So the treating approach is there's no definitive cause found in the functional dyspepsia. Multi-pathological factors and psychological factors also involved, overlap with other conditions. So limited effective therapies and focus should be on symptom management. Next. So meticulous history is very important in differentiating between functional and organic dyspepsia. Next. And also alarming symptom needs to be evaluated before labeling them and subjecting them for the further evaluation. Next. So in few cases, especially we don't use these tests for every case, like functional dyspepsia, most of the time we manage empirically. If at all the patient not responding to treatment and associated with other alarming signs, then we subject them for gastric emptying studies and gastric accommodation studies using Borostat or a PET-CT or sensory function test and myoelectrical activity by antoduodenal manometry. And this is all, most of the time it is used in research purpose rather than clinical case-to-case management. So whenever required, we can use this. Next. So I'll summarize my presentation. Functional dyspepsia is global phenomena where epigastric pain, postprandial fullness, early satiety, and bloating. These are the various classical symptoms they present with. So room 4 criteria has defined the type phenotypes. When you fit the patient to the particular phenotype, the management issues are easy and management is easy. And diagnosis is always a thorough clinical history and examination, prompt search for the organic cause by endoscopy and other tests. Then management challenges are, we know that there's no definitive therapy and psychosocial overlap. And most of the time, when look at the treatment options, the best one is the PPI. Or when you best part is the effective therapies are, one is you need to develop a good rapport with the patient, and PPI are the best medicine for short-term duration, and as well as we have a definitive therapy like acostamide whenever we establish the fundic dilatation. If there's no fundic relaxation, then we can use acostamide. Our tricyclic antidepressant play an important role in managing these cases. So the treatment approaches and other things that the co-speaker will speak in the next presentation. Thank you.
Thank you, Dr. Lokesh. I think you covered this topic in a very short time and give all the details that were necessary. It's really a difficult job that you have done. Wonderful. So I think I'll move on to Dr. Avinash to go on to how to manage these patients. That's the most difficult part. Dr. Avinash, please.
Yeah. Good evening, one and all. At the outset, I would like to thank Dr. Shobna Bedi, Madam, and all the team Lupin for giving me this opportunity to present to you today on management of functional dyspepsia. I think Dr. Lokesh has covered extensively on the clinical features, predominantly whether it is epigastric pain and burning. So where we say that it is EPS, epigastric pain syndrome, and the postprandial fullness and early satiety. So this is predominantly postprandial distress syndrome. My outline of the talk in the next 15 minutes or so. So this is the headings that I will be covering. One is the first one will be H. pylori associated dyspepsia, predominantly a role of anti-H. pylori treatment. Acid hypersecretion, role of PPIs, and nowadays the new entrant, that is a PCABs. Dysmotility in functional dyspepsia, role of prokinetics. Visual hypersensitivity, role of tricyclics. And the topic of today's interest, which is the acostamide. So this is the typical prototype case that we see in a day-to-day practice. 40-year-old male, bothersome postprandial fullness with epigastric pain for 6 months without any alarm symptoms. or comorbidities. The routine blood investigations bang normal. So he has tried n number of gastric medications. Nowadays, ChatGPT as well as Google plays a big role, and he asked majority of the time, can it H. pylori? So because we are in a H. pylori endemic zone, so the most important thing, like we can see that there is 60 to 80% positivity rate either in functional dyspepsia or in normal population, and eradication rate with the standard triple therapy for H. pylori is almost to the tune of 70%. So, but symptom resolution at 1 month with triple therapy is 60%. At the end of 1 year, it becomes only around 43.7%. But problem is there is no additional benefit even after healing of the gastritis. These are all the couple of articles, one from Kashmir, where the eradication of H. pylori does not resolve the symptoms of functional dyspepsia. And Indian scenario, majority of the articles are by Dr. Uday Ghoshal sir. So where many RCTs have shown that some symptom resolution after H. pylori eradication. This is one from our center, where whenever we make a diagnosis of H. pylori, so it can be non-invasive, as Dr. Lokesh has already mentioned, either it can be urea blood test or a stool antigen test. So invasive predominantly is always with an indication like endoscopy is there. So always please ensure that we tend to go for rapid urease test as well as biopsy, both from the body as well as from the antrum of the stomach. That will give us a better read. But the most important thing is we should ensure that the patient is off antibiotics for at least 4 weeks and off PPIs for at least 2 weeks. But another important thing is a negative test does not completely exclude H. pylori. So there is basically a systematic review and network meta-analysis which got published in BMJ 2019. So where they determined the effectiveness of different management strategies for uninvestigated dyspepsia. The study included 15 eligible randomized control trials with more than 6,000 adult participations. In that, the conclusive statement is test and treat is the way to go. And endoscopy always excludes that there is no major problem for the patient, and it ensures that the patient gets maximally satisfied with the doctor's consultation. So again, one more article where test and treat for H. pylori dyspepsia, 17 RCTs, 3,000 odd patients. Number needed to treat were 13. And patients with presenting with pain and the burn, they respond better in contrast to patients who are presenting with predominantly bloating and satiety. So eradication therapy benefits always outweighs the risk, because H. pylori, once it is eradicated, the chance of patients developing either peptic ulcer disease or pre-malignant conditions or malignancy also can be reduced. So the article mentions that the only good H. pylori is a dead H. pylori. So there are different regimens that are documented. It's an obligate anaerobe, very difficult to culture, very difficult to identify resistance patterns. Majority of the time, we tend to use a standard triple therapy or a concomitant quadruple therapy. Predominantly, standard triple contains 2 antibiotics and 1 PPI. Amoxicillin, please ensure that it contains 1 gram twice in a day. Clarithromycin, 500 milligram twice in a day. PPI, whether it is pantoprazole or esomeprazole, 40 milligram twice in a day. So this is double dosing. So it has got an efficacy of 78 to 84%. So if at all it fails or still positivity, we can go for concomitant where it is a quadruple therapy, PPI, amox, bismuth or metro plus clarithromycin. Hybrid and sequential, these are all reported in literature, but it becomes a little difficult to explain to the patient, but predominantly they are around 80 to 90% efficacy rate. Now coming to the second objective, the most important crux situation, there is a burn, there is a probable acid hypersecretion. Majority of the patients will not be willing for 24-hour pH metry or anything, but predominantly the evolution of acid suppression therapies, if you see in 19th century, is predominantly the lifestyle measures and the antacids. 70s, we got the H2 receptor antagonist, prokinetics. 80s is the origin of the proton pump inhibitors, and 2021 on, predominantly we tend to have more of potassium channel competitive acid blockers. Why the PPIs and PCABs are coming up in a big way? We all know that the final common pathway where the movie is going to end, that is where is a catchment. The final common pathway is the one that is a H plus K plus ATPase. So where there is a blockage, that has got the maximum acid suppression as well as a maximum symptom relief. So this is again a Cochrane database systemic review where there is a PPI role in functional dyspepsia, which included 23 RCTs, 8,000 odd patients. And it has noted that PPI is much better than placebo with a relative risk of 0.8. Number needed to treat were 13. including a combination of a prokinetic also is better. So predominantly number needed to treat were 18. So predominantly a standard dose we are going to use. We are not going to use a double dose PPI. Both the patients, either it is a pain dominant or a bloating dominant. 8 weeks is always better than the 4 weeks, provided they don't have alarm symptoms. If there is no response at 8 weeks, it is better to stop and then revisit the history, whether we are dealing with a secondary dyspepsia. If there is a response, it is better to taper after 8 weeks. SOS should always be there in the prescription. SOS is either it is a H2 receptor antagonist or an antacid or an alginate if at all there is a reflex overlap. Benefits are marginal because it's a functional dyspepsia. Most important, age more than 60 years, comorbidities, we should always ensure that they don't land up with adverse reactions. If the person is after 8 weeks still wants to take PPI, it's always better to exclude an organicity by doing an endoscopy. The new entrant from 2021 is the PCABs, that is potassium channel competitive acid blockers. A lot of you would have used this molecule, vonoprazan, which is the first of the PCAB molecules, similar to omeprazole in PPIs. It is a super concentrate in the parietal cell, competitively inhibits the potassium H plus K plus ATPase enzyme, reversible, meal independent, faster in action, as well as basically it covers both morning as well as the nocturnal acid suppression. So highly potent, rapid onset. But we tend to have more entrants apart from the vonoprazan. These are all the other PCABs that are going to come into the market. Already fetsuprazan and tegoprazan have already entered into Indian market. Keverprazan is going to come, whereas the phase 3 studies are showing a promising trial in Korea, like linazepam, gluten, and zestaprazan. So these are all the potassium channel acid blockers. Among these, vonoprazan and tegoprazan are only allowed for the H. pylori. So they are similar or better efficacy in comparison to the PPIs. They are predominantly the data is on the short term, but long-term treatment in Indian patients is needed. Now we come to the third important thing where there is a dysmotility and the role of prokinetics in functional dyspepsia. As Dr. Lokesh has already mentioned, gastric emptying can be delayed in 40% of functional dyspepsia patient with predominantly a fundic relaxation. Like predominantly stomach is a very unique organ where the proximal fundus accommodates, that is it relaxes so that more amount of food can go in. Whereas a distal stomach is an antral hypermotility that is going to push the food across the pylorus. So predominantly it works both the ways. Predominantly we are looking at the proximal gastroduodenal scenario. So like in functional dyspepsia, there can be increased intestinal motility, as well as sometimes whenever we tend to look at the prokinetics, we should always keep in mind what are all the adverse drug reactions in contrast in relation to that particular prokinetic. Again, the Cochrane database review, which included 29 trials, prokinetics are little better than placebo. Number needed to treat or response is predominantly 7. Global symptoms more or less are same, but it is predominantly a low quality study. The most important thing we need to remember in prokinetics is majority are D2 antagonism that is going to work proximally, along with a 5-HT3 antagonist or 5-HT4 agonist, like either domperidone, metoclopramide, or levosulfide. The unique thing of etopride as well as acosamide, etopride is D2 antagonist as well as acetylcholine esterase inhibitor. The acosamide, which is a topic of interest for today, which is predominantly muscarinic 1 and 2 receptor antagonist, as well as acetylcholine esterase inhibitor. So majority of the prokinetics, which are D2 antagonism. So in domperidone, we should always remember that it may cause little QT prolongation because they are dopamine. So we need to look at like there can be a chance of gynecomastia as well as galactoria. Some of these molecules can cause blood-brain barrier, may cause either transient or a permanent, like extrapyramidal side effects in terms of Parkinsonism. Sometimes a permanent can be a tardive dyskinesia. So we should always keep in mind these patients, whenever you are giving prokinetic, give a schedule of 1 month, 2 months. Don't keep on continuing like a PPI. But etopride and acosamide, they are much more safer molecules because they don't have much on the QT prolonged cardiac or the CNS risk factor. Now the fourth component, which is predominantly visual hypersensitivity and the role of tricyclics. So we tend to deal majority as a mild 70%, which generally have intermittent symptoms. They will be like managed at the primary care level. So like majority of these people will be taking off and on SOS PPIs, which is actually not documented in the test book, but a lot of patients, they get the molecule on the over the counter. But the problem is the severe functional dyspepsia patients where the symptoms are constant. They keep meeting multiple doctors. So without any much of a satisfaction, those are all the patients where we may have to look at the doctor-patient relationship, like what brought you today, because at the end, the patient engagement, empathy, validation of the symptoms with because at the end, it needs to lead to patient satisfaction. Unless and until we spend time with these patients, they don't understand what is the interaction of disorders of gut-brain interaction. Then it becomes a little difficult for us to convince them either to meet a psychiatrist or to take a tricyclic antidepressant or SNRIs or SSRIs, like venlafaxine and all are coming in a big way. So these are all because of the maladaptive coping for their stressor, which is there in their day-to-day practice. Their gut is a second brain and they tend to have these dyspeptic symptoms. So now the last part, which is the most important, that is the role of acoshamide. So this is a typical presynaptic and a postsynaptic scenario where there is excitatory cholinergic nerves which are going to secrete the acetylcholine, and this acetylcholine is going to get attached to the receptor on the other side, which is predominantly on the smooth muscle, and then it allows either in the fundus the relaxation and in the antrum the hypermotility. So whenever there is excess acetylcholine, so like by inhibition of acetylcholinesterase, this muscarinic effect will be much more. So whenever there is excess acetylcholine, as well as there will be a negative feedback to the muscarinic receptor that there is already an excess acetylcholine that is coming, so please stop. So acoshamide works at both the levels. It is going to inhibit the acetylcholinesterase enzyme, thereby the acetylcholine will be more, as well as it is going to inhibit the negative feedback at the receptor level. So this is a mechanism of action of this acoshamide. So it is predominantly a orally given molecule. There is no IV acoshamide. So the adult dosing is predominantly 100 milligram 3 times in a day. Predominantly it needs to be given before a meal. Someone is going to a party, so he wants to eat more at a party. So this is a molecule I think we can safely give. So mechanism of action I have covered, and indication is predominantly postprandial fullness, upper abdominal bloating, as well as early satiety, predominantly in functional dyspepsia. So Tmax is 1 to 1.5 hours, predominantly glucuronide metabolism, and 45% of the molecule is going to be excreted in the feces. So there is no cardiac, no QT prolongation. So we should not be worried for prescribing or concomitant prescription in a cardiac comorbidities, and there is no significant inhibitory effect on cytochrome P450. So now couple of studies. So I got them from the company. So this is one study. So where 200 odd patients received 100 milligram of acoshamide 3 times in a day for almost like 1 year period. This is a European phase 3 open label study, got published in Neurogastroenterology Motility in 2018. Predominantly, they looked at the functional dyspepsia symptoms, quality of life, work productivity. So as well as the safety follow-up with adverse effects, ECG, laboratory, vital signs, and a physical examination. So not going into the depth of the study, predominantly the conclusion is like almost more than 80% of the patients maintained or completed the study. That is, they continued for more than 50 weeks. So, and there is no specific clinically significant safety concern, no deaths. So it is very safe molecule. And predominantly, it has shown much improvement in meal-related symptom severity, as well as overall treatment evaluation, quality of life, as well as work productivity. So this is the first long-term safety trial. You can see that almost it has gone up to 1 year's continuation of this molecule, that it can be safely administered. So some of the patients will be Googling, so they will be asking any side effects. So predominantly there can be little nausea, abdominal distension, and constipation to the tune of only 1%. That means 99% of the patients generally tolerate this molecule. So then the second study, like predominantly it is a placebo control trial of acoshamide for meal-related symptoms and functional dyspepsia, which is an older study like GUT to 2012. It is a multi-center RCT. But the important thing is like 400 in each group, and it is a randomized phase 3 trial. So where 100 milligram thrice in a day acoshamide is given for 4 weeks. And after that, a post-treatment follow-up of 4 weeks, predominantly again, majority in the functional studies, the symptom correlation will be asked with a questionnaire. So the predominantly lot of patients will be asking like once they take a molecule, when the onset of action or when they will find the improvement of the symptoms. That is what this is going to give an answer. So we need to tell that at least week 2 or week 3 is a time when they start feeling the improvement of their symptoms. So even after stopping the molecule after 4 weeks, during the post-treatment follow-up of 4 weeks, none of the patients actually had a relapse of the symptoms. So there is a higher response rate of acoshamide as compared to placebo. But most important thing is the onset of action of acoshamide, even though we start 100 milligram 3 times in a day. So we need to tell them that it may take 2 to 3 weeks time for them to see the response of the symptoms, and it is going to persist even after 1 month after stopping the molecule. So this is my last slide. So patients who are presenting with epigastric pain, burning, early satiety or postprandial fullness for more than 6 months, as Lokesh has mentioned about the alarm symptoms, we are going to ask if they are present, no matter what is the age, they need to get an endoscopy to rule out an organic dyspepsia. If there are no alarm symptoms, endoscopy is normal, local H. pylori prevalence is more than 10%, which majority in India. So then non-invasive test or a stool antigen test after discontinuation of PPI for more than 2 weeks. If it is positive, you can treat with H. pylori. If it is like success for the dyspepsia, so then we are going to document it as H. pylori related dyspepsia. If at all after H. pylori eradication still symptoms persist and local H. pylori prevalence is much lesser, then we need to look at what is the dominant symptom. If the patient is predominantly like a bloating, early satiety, that is, they are not able to complete their normal breakfast. So then we need to give the novel, the unique molecule that is predominantly acoshamide at 100 milligram thrice in a day. So predominantly, if at all they are going to respond at 4 weeks or 6 weeks scenarios, these are all the patients whom we are going to label them as postprandial distress syndrome. And then we are going to give at least for a period of 2 to 3 months, and then we are going to stop the molecule and then see. So because if you keep on continuing the molecule, sometimes the effect may wean off. So it's always better to follow a principle what are called as drug holidays. So where we can change over the molecule and then see the response. If the pain is predominantly the dominant, we like predominantly pain or the burning, you can give an empirical acid suppression therapy for 4 to 8 weeks time. So and then you can again try a drug holiday for 3 months. So suppose the patient keeps coming that it is not working. So you can change the PPI. You can change the PPI instead of morning dose to the evening dose. If still failure, you can try it. Like if the person age is less than 60, there is no urinary retention scenario, you can safely give amitriptyline at 10 to 25 milligram at night time. But most important thing is we need to ask the patient to come back after 3 months, because the dose that we give, the dose the psychiatrist will give is completely different. So we give 1/5 of the dose. So the effect itself, we need to explain that it may take 1 month to 6 weeks time to act. So if there is a failure of the tricyclic antidepressant, then we may have to have a consultation liaison with the psychiatrist. Otherwise, we may lose on the patients. I think this is my last slide, and thank you one and all for the patient hearing, and thank you, madam, once again for the opportunity.
Thank you, Dr. Avinash. I think both of you did a fantastic job of a topic that is very, very complicated. It's a wonderful job, I think. So can we have the questions, if there are any from the audience, and then I can ask a few more from both of them.
Yeah, Dr. Manisha, can you just put up the questions for Dr. Shobna so that she can take up to Dr. Lokesh and Dr. Avinash?
Okay, so then let me just put in a very simple question to both of you. The first one is, in a patient who comes with this terrible epigastric discomfort, how do you decide which symptom tells you that this is going to be EPS or PDS? You both described it in great detail. So how can you just, in 2 minutes while the patient is talking, you decide this patient had delayed motility, this patient has an accommodation problem. So Dr. Lokesh, since you talked about pathophysiology, what
Now,
are the questions you ask the patient?
so I'll ask the patient whether the patient, what is their predominant symptom, whether it's a burning sensation in the epigastric region or pain, or whether when they eat something, even with a short meal, they feel like early satiety. And the other part
Yes,
is postprandial, what time the postprandial discomfort start and what time it persists. So these four
right.
leading questions sometimes lead us to whether what kind of phenotype we are dealing with.
Yes,
So if it is early satiety, then definitely fundic relaxation failure. Or if there is a postprandial distress or discomfort within 30 minutes of onset, I mean after intake of food, that indicates more in favor of PDS compared to the bloating and discomfort. Even we experience in IBS patients also. So that
yes.
is really late onset. So I think these four symptoms will definitely leading questions will help us to delineate to some extent.
Very good. I think that's a wonderful answer. In fact, there are some studies which, if Manisha does not have any questions, just talk about this. So you did talk about, the accommodation tests. So sometimes, you tell the patient to have a little bit of water, see what he feels like, have a little more of water. And there is a test to do, a way to do this. And sometimes, even without their knowledge, patients might actually have 200 to 300 ml. So part of this lack of relaxation may actually be, functional, and they are unable to just relax their fundus. Yes, so that's very important. So many of these patients also sometimes lose weight because they're not able to complete a full meal. And as you directly pointed out, that weight loss, then you directly have to do an endoscopy to rule out a fundic malignancy. So Dr. Manisha, any questions?
She has posted few questions in WhatsApp group, madam. Can I read out, madam?
No, she
Probably.
said she would read them out. So I'm waiting for her to read them out. Okay, I will read them out then. Okay, she must have
I think
sent it to me
she's
also.
pleased with, she has some connection issues, so she said that.
Okay, so if you, Dr. Lokesh, if you have
Yeah,
them,
yeah,
please,
yeah. I
please
can
put
see,
them
madam.
up and we
So
can.
the
Yes.
question is from Rohan V, where they say like, how important is the duration and frequency of symptoms in diagnosing functional dyspepsia according to current Rome criteria, Rome 4?
So very good. I think that you can take this question, Dr. Lokesh.
So it's basically like to exclude the transient illnesses, especially like gastritis, post-viral, or sometime NSAID induced, or some other transient acute gastritis. They kept a time period, and also for evaluation of a chronic illness and labeling a chronic illness, functional disease, we need a time period. Many diseases, many symptoms will persist for 1 to 2 months and then subside. So they kept at least minimum 3 months, and the answer should be 6 months prior to the labeling diagnosis. This is why they kept a time period.
And another reason, Dr. Lokesh, is that many of these patients who may be missed as a serious illness. So somebody has an illness for 1 month and starting at an older age, we should not be thinking of functional disorders. Somebody who's a 50-year-old or a 60-year-old person comes for the first time with what looks like functional dyspepsia. There is mild weight loss, lack of appetite, and if they are treated as functional dyspepsia, then for a few months they get, mild relief, and they may not be seeing the doctor, and we may miss a serious problem here. So that 6 months is their minimum to call it functional. Less than that, in an elderly person with alarm symptoms, they should be investigated immediately. Okay. Yeah. What's the next question, Dr. Lokesh? I don't have access to the WhatsApp right now.
But
Dr.
I
Avinash,
think,
can you look at the questions?
yeah, madam,
Yes,
but
tell
I
me.
think the majority of the guidelines are from the West, madam, so where the access to the endoscopy is much lesser. So in India, like we have now
Yes.
many gastroenterologists are doing endoscopy. So majority of the time they will come with an endoscopy report saying that they're not responding. So like I think
So that's a very valid point. But sometimes what happens, the patient delays the investigations
Yeah.
and say, I have symptoms only for 15 days. I have symptoms only for 1 month. And that is where the dangerous part is. You know,
Yeah.
I'm not saying that get the endoscopy done in, say, a week of symptoms, but I would definitely suggest that don't wait too long because you're going to miss a serious disorder. Yes, Dr. Manisha.
Yes, ma'am. Am I audible and visible now?
Yes, definitely.
Okay, sorry for the disconnect because there was, I think, internet related some issue was there with me.
Mm.
So there are a few questions actually I received. So if you allow me, I will just read out for you. Okay. So
First
one
question.
first question is done, I guess.
Mm.
So the second question was about these are very generalized question, but important from the practice point of view that patients often overlap with FD symptoms and IBS. If yes, how do you clinically differentiate between two in the routine care?
So, Dr. Lokesh, do you want to take this? Dr. Lokesh?
No, I think he's.
Yeah, why don't you take it, Dr. Avinash? I think
Yes,
Dr.
madam. So,
Lokesh
like,
is.
I think very important question in day-to-day practice, like predominantly in postprandial fullness, like it is predominantly immediately after having a food, that is 30 minutes after. So that typically points out to the gastroduodenal dysmotility. In IBS, there can be a chance of small intestinal dysmotility, or there can be a overlap of small intestinal bacterial growth, where there can be a chance of bloating, similar like more gaseous symptoms. So like predominantly whenever it is much farther away from the meal, then we think that it is a irritable bowel syndrome. Second thing is predominantly in irritable bowel syndrome, it starts with abdominal pain. So like that is the clinching diagnosis for IBS. It is not predominantly the burn. So here in functional dyspepsia, it is predominantly the burn that makes, and it is predominantly the meal relation immediately after the food. So that is what differentiates it from the IBS, but saying that both the things are predominantly disorders of gut-brain interaction. So they come under an entity of functional bowel disorders. So predominantly the upper GA1 is the functional dyspepsia. Predominantly the lower can be the irritable bowel syndrome, which has got the relation with the bowel frequency or the consistency. I think anything
Yeah.
else?
So the main thing is that in IBS, there will be some form of either constipation or change in bowel habits, which is very important. And in at least 40 to 50% of cases, there will be patients of IBS will have symptoms of upper GI tract. So it's never, you cannot divide the bowel and say that if there are gastric symptoms, there will not be any bowel symptoms or vice versa. So, you have to balance them. Okay, next question, Dr. Manisha.
Yes. Ma'am, very interesting question actually has come that somebody is asking about, is there any change in the presentation trend over a period of time this year? Like perhaps due to dietary habit change or H. pylori, increased prevalence of H. pylori or any stress level associated with it. So is there any change in the trend?
Not that we are aware of, but overall, if you see the whole Indian population, a lot of us have H. pylori present. And patients who come to us get that eradicated. But the rest of them continue to have their H. pylori. So over a period of say 20 to 30 years, the H. pylori prevalence will go down because we now have access to clean water and clean food. And people are moving towards that, clean water and clean food. So that will make a difference to H. pylori. But when you add to it the changes in diet and the changes in stress, the number of patients with functional dyspepsia will probably remain the same. So we are not going to be changing much of that. Dr. Avinash and Lokesh, do you think there's something different you want to add?
No, madam, I'll go with you.
Okay,
Because the
thank you.
prevalence is coming down, but most of the time, because the fast food centers have increased and a lot of dyspepsia secondary to food intake, like food habits as well as timing, as well as high fatty food and high calorie food, we are getting more and more dyspeptic patients.
Absolutely, correct. Yes, Dr. Manisha.
Yes. There is one question, ma'am. There is a role of screening for food intolerance or dietary pattern. And how useful is the dietary modification in the real world practice? Is there any
Dr.
association?
Avinash,
Yes, madam. So it's a very important question because a lot of people will be already on a restrictive eating habits. So it becomes very difficult for us to convince that those items are not going to impact because that is what the textbook tells. But majority of the time, because at the end the patient is the boss. So the thing is like if they identify that this is a trigger, and we just tell them that if you keep on restricting, then the nutritional component may have a problem. So, we just explain them that it is a trick of moderation. So, they may have to figure out rather than 0 and 100, try to reduce on it and then take it from there. Second important thing is it's always better to have a microscopic anatomy, that is endoscopy plus a duodenal and a gastric biopsy for ruling out that whether the person actually has got an eosinophilic or a celiac, so anything which can imply or implicate a dietary modification as far as the etiological perspective is considered. But it is a very important question in a day-to-day practice. Yes, madam.
correct.
As such, I mean, I want to add one more point, madam. When you look at the pathophysiology, there's been, hypothesized that there is increased eosinophils in the duodenum and IEL cells. There is some amount of inflammatory activity happening in the duodenum in all dyspeptic patients. I mean, to certain patients, certain percentage of patients. Probably the food may be a trigger, like how the celiac, it's not a non-celiac kind of gluten hypersensitivity or some kind of FODMAP triggers could be a possibility. So in such a case, we can recommend, as sir said, they can tailor their food habits based on the triggers, and it's not like blanket statement. But we have seen certain, functional dyspepsia patient not responding. We had a drug like LDCET or some other drug or TCS, they respond well. Like there's some visual hypersensitivity, food could be a trigger.
Right. So I'll just add to this that when a patient of functional dyspepsia does not respond, it's important to get the D2 biopsies, take biopsies from the second part of the duodenum and also sometimes the stomach if you find abnormalities, because these patients may have eosinophilia. And if that is there, then we should look at foods that could trigger it. Unfortunately, patients start avoiding these foods on their own. They will start avoiding certain vegetables, proteins, and then they actually become deficient. And that is something that we have to be very careful about. So very happy this question has been asked. We've got to be careful before we advise patients blanketly that, you stop all these items and then you will get better. They don't get better, but by then they have become deficient. So we got to be careful. Yeah. I think she's gone off screen again. Dr. Lokesh,
Yeah,
are there
I'll
any
see,
more
madam.
questions that you have found?
No, madam, I
Yes.
think we have answered all the questions, madam. Role of screening,
Okay.
food intolerance, and yeah, we have answered, madam.
Okay, so that's wonderful. It was a big learning session for me also, and I'm sure the audience definitely learned from both of you. I'm very happy that this session was taken. Dr. Nidhi? Nidhi?
Yeah, ma'am, I'm
Yeah,
here.
sorry. Sorry.
Ma'am, I'm still a very humble person without any doctor. You guys are
No,
such an
sorry, I'm
esteemed
sorry.
doctor for us, and it's really a nice session. And Shailesh from HO is also here, so he wants to put the last remarks for the session.
Okay.
So, Shailesh,
Hello,
over to you.
very good evening, ma'am, and to both the speakers, very good evening. And we really thank you, ma'am, for accepting our invite today for this session, and also to Dr. Lokesh and Dr. Avinash. Thank you for coming in and enlightening the audience with your thoughts. And really, it was a true learning session for each one of us today, ma'am. Thank you for joining, ma'am.
Thank you.
Thank you.
Wonderful.
Ma'am.
Thank you to Lupin
Thank
and
you.
their team for giving
Yeah.
us this opportunity.
And we'll give you a glimpse of how many attendees. So 1,000+ doctors have again joined us from
Wow.
all India, and
Wow.
looking forward for such more doctors' attention towards this kind of a webinar, which is really impactful and knowledgeable from the esteemed doctors for this. So thank you.
Thank
We
you.
are doing it on time, and thank you for your time. So
Thank you.
thank you all doctors who are watching us, and see you again next month for new updates with functional dyspepsia. Thank
Thank
you.
you.
Thank you.
madam.
Thank you, everyone.
Thank you, Nidhi.
Bye.
Thank
Bye.
you.
Thank you, sir.
Thank
Have a nice day. Thank you.
Thank you. Thank you. Thank you.
Yogita,
Thank
you
you
can,
so much,
uh,
yes. Thank you so much, everyone, for giving your valuable time. So from here, I'm ending this meeting. Thank you.
Yeah. Thank you. Thank you, Dr. Avinash and Dr. Lokesh. Yeah, thank you. Bye.